Hello and welcome. Today we're diving into a rare and often overlooked condition affecting the kidney's heavy chain deposition disease, or HCDD. The exact cause of heavy chain deposition disease remains somewhat elusive, but it is generally considered a plasma cell dyscrasia. This means it arises from an abnormal proliferation of plasma cells in the bone marrow. These rogue plasma cells then produce abnormal immunoglobulin heavy chains, typically IgG or, less commonly, IM. Instead of forming complete functional antibodies, these heavy chains are structurally flawed, lacking light chains, or having other alterations that prevent them from being properly cleared from the body. Certain genetic predispositions or triggers might contribute to the development of this disease, but definitive causative factors are still under investigation. The pathophysiology of HCDD centers around the deposition of these abnormal immunoglobulin heavy chains in various tissues, most notably the kidneys. These heavy chains precipitate out of the bloodstream and accumulate in the glomerular basement membrane, the delicate filtering structure of the kidney. This deposition leads to thickening of the basement membrane and subsequent glomerular damage. The damage disrupts the kidney's filtration process, causing proteinuria, the presence of excessive protein in the urine. Over time, the chronic deposition leads to inflammation, scarring, and ultimately, kidney failure. Less frequently, these heavy chains can deposit in other organs like the liver, heart, or even the nervous system, leading to dysfunction in those areas as well. Heavy chain deposition disease is a rare disorder, and precise epidemiological data are limited. It's challenging to determine the exact prevalence, as the disease can often be misdiagnosed or overlooked. HCD can affect individuals of any age, though it is more commonly diagnosed in adults, particularly those over 50. There does not appear to be a significant gender predilection. Due to its rarity, large-scale epidemiological studies are lacking, making it difficult to pinpoint specific risk factors or geographic variations. The signs and symptoms of heavy chain deposition disease are often non-specific and can mimic other kidney disorders. The most common presenting symptom is proteinuria, often discovered during routine urine testing. This can lead to edema or swelling, particularly in the legs and ankles. As kidney function declines, patients may experience fatigue, nausea, loss of appetite, and shortness of breath. Elevated blood pressure is also a common finding. In cases where heavy chains deposit in other organs, symptoms can vary widely. For example, liver involvement might cause jaundice, while cardiac involvement could lead to heart failure symptoms. Diagnosing heavy chain deposition disease can be challenging due to its rarity and the overlap of symptoms with other kidney diseases. The diagnostic process typically begins with a thorough medical history and physical examination, followed by laboratory tests. A urine analysis will reveal significant proteinuria. Blood tests may show elevated creatinine and blood urea nitrogen levels indicative of impaired kidney function. Serum protein electrophoresis and immunofixation can help identify abnormal immunoglobulin heavy chains in the blood. However, the definitive diagnosis requires a kidney biopsy. Microscopic examination of the biopsy sample, along with immunofluorescence or immunohistochemistry staining, will reveal the characteristic deposition of heavy chains within the glomeruli. While there aren't distinct types or classifications of heavy chain deposition disease in the same way as some other diseases, it's important to note the specific heavy chain involved as IgA, or IgMs, as this might influence the overall clinical presentation and response to treatment. Also, the extent of organ involvement beyond the kidneys can vary significantly from patient to patient. The treatment of heavy chain deposition disease focuses on suppressing the abnormal plasma cell proliferation and managing the kidney damage. Chemotherapy regimens, similar to those used in treating multiple myeloma, are often employed to reduce the production of abnormal heavy chains. These may include agents like cyclophosphamide, bortezomib, or lenalidomide. In some cases, autologous stem cell transplantation may be considered. Supportive care is crucial, including medications to control blood pressure, reduce proteinuria, such as ACE inhibitors or ARBs, and manage edema. Ultimately, if kidney function declines to end-stage renal disease, dialysis or kidney transplantation may become necessary. Currently, there are no specific preventative measures for heavy chain deposition disease, given that the exact cause remains unknown. Maintaining a healthy lifestyle, including a balanced diet, regular exercise, and avoiding exposure to known kidney toxins, can help promote overall kidney health. However, these measures will not directly prevent the development of HCDD. The prognosis for heavy chain deposition disease can vary significantly depending on the extent of kidney damage at diagnosis and the response to treatment. Unfortunately, the disease often progresses to end-stage renal disease despite treatment. Early diagnosis and aggressive therapy are crucial for improving outcomes. Research into novel therapeutic targets is ongoing, focusing on specifically inhibiting the production or deposition of abnormal heavy chains. Furthermore, studies are exploring the potential role of targeted therapies and personalized medicine approaches to tailor treatment to the individual patient's disease characteristics. More data is needed to fully understand the long-term outcomes and optimize treatment strategies for this rare and challenging condition.